I'm delighted to introduce our speaker for today, Dr. Andrew Folpe, who really needs no introduction. Andrew is a professor and consultant in the Division of Anatomic Pathology and has been here for some time. He attended the Amherst College as an undergraduate before doing medical school at the University of Rochester. That's the other less famous Rochester in New York. And he performed his residency in anatomic pathology at the University of Washington in Seattle. He did some additional training with luminaries in the field, Doctors Alan Gone in immunohistochemistry and Sharon Weiss in soft tissue pathology, before becoming in his own right a real master in the field of anatomic pathology. To say that Andrew is well recognized and highly sought after would be a tremendous understatement. I was a part of 2 congresses last year where Andrew was giving talks internationally. I see him always around giving lots of presentations and being invited to speak. If you look at the specific numbers, he's authored over 200 publications, principally in the area of soft tissue pathology and diagnostic immunohistochemistry. He is the co-author of one of the key texts in pathology, the Enzinger-Weiss soft tissue tumor text, both the 6th and 7th editions. He is one of the members of the editorial boards for the 3rd, 4th, and 5th editions of the WHO classification of tumors, which is a very prestigious and important responsibility. He is the co-chair of a Mayo Clinic Cancer Center Sarcoma Disease Group. He has directed the Bonus Soft Tissue Pathology Fellowship for a number of years, and he is also on the editorial board and the associate editor for the Modern Pathology, which is the most prestigious journal in our field. He has lectured widely on a variety of topics related to soft tissue pathology and diagnostic immunohistochemistry. So while he has been incredibly successful academically, he does have a very active set of hobbies. He is an avid cyclist and hiker. I've heard from many people that he's actually a very good chef and he does a lot of baking, including baking bread. And he really loves spending time with his dogs and his family. So without further ado, I introduce to you Dr. Andrew Folpe. Andrew?
Well, thank you very much, Randolph, for the nice introduction. So the topic today is applications of molecular pathology in the diagnosis of soft tissue neoplasms. And this was something that originally I worked up for a clinical audience. And then basically, I thought it would be sort of applicable also for pathologists in other areas, because so much of what we do in pathology now and in sarcoma care is multidisciplinary. I think it's important that we all understand what each of us is doing. And so this, in a sense, is kind of a behind the curtain talk. All right, so I have no disclosures. Here are some learning objectives. All right, so a little bit of background about soft tissue tumors. So sarcomas are quite rare, right? They comprise less than 1% of all malignant tumors with an annual incidence of about 30 million, which gives us about 11,000 soft tissue sarcomas a year. And just, by way of comparison, there are 209,000 breast cancers. So we're dealing with a rare disease. Compounding the problem, benign soft tissue tumors are at least 100 times more common than sarcomas. So one of the recurring issues that we have in soft tissue pathology is actually benign lesions mimicking malignant lesions. Most pathologists and clinicians, even at excellent institutions, have very limited experience with soft tissue tumors. And this is in part because there are hundreds of different tumor types. Unlike a lot of clinical diseases, a lot of soft tissue tumors present in a very non-specific fashion. And unfortunately for us as pathologists, many of them have deceptively pseudo-benign or pseudo-malignant morphologic features. And so the diagnosis of soft tissue tumors and their classification is really a team effort. It requires clinical correlation, morphologic expertise, application of immunohistochemistry, and as we'll talk about for the most part in this lecture, understanding of the uses and limitations of molecular genetic techniques, as well as discussion with our colleagues in various disciplines. All right, now let's get this one out of the way first. Sometimes you'll get clinicians or other pathologists say, well, I don't really care what we're going to call this thing. Let's just grade it. Let's just tell them how bad it is. And so we'll play a little game with that. This is the grading system that we use. It's the French sarcoma grading system. You give tumors a differentiation score. You can see here 1, 2, or 3. This is very, very subjective. You count mitoses, and so you give a score. You look for necrosis, and you give a score, and then you add it all up, and you give a grade. So seems pretty straightforward, right? All right, so what is this tumor's grade? Let's play the game. So again, differentiation is the most subjective part. So let's just, for the sake of argument, say this is moderately differentiated. So we'll give it a 2. It's easy to find mitoses. Here's one right here. There's probably another one somewhere else. And this one actually is necrosis. So, you know, if we add it up and you go back and look at the chart, we probably have a grade 2 sarcoma, right? Wrong. This is nodular fasciitis. So this is a completely benign neoplasm. And it just basically shows that grading and many other things that we do in soft tissue pathology are really meaningless until we have the correct diagnosis. All right, so how do I approach a soft tissue tumor? Well, I want to know clinical information. I think this business of being the pathologist who says, you know, I don't want to know anything, I'm just going to do it off the slides, that's kind of silly and kind of a waste of time. We all went to medical school, we should use that information. So I want to use the patient age. I want to know the patient age and sex. I want to know where the tumor is located, how big it is, and how deep it is. And of course, I'd like to know relevant clinical history if the clinicians would be kind enough to provide it. Once I start looking at it, then the question becomes, well, is it a mesenchymal tumor or it is a non-mesenchymal mimic? And I sometimes tell our fellows that, you know, at least half of what we do in soft tissue consultation is telling people, no, that's not a soft tissue tumor. That's a funny manifestation of renal cell cancer or something else. Then we try to decide, is it a reactive process? Is it inflammatory? Is it infectious? Is it neoplastic? Can I say right off the bat if it's benign or malignant, or does the tumor have some clues that perhaps it's a pseudo-benign or a pseudo-malignant lesion? Once I've gone through that sort of thought process, then I have to ask the question, is morphology alone sufficient for diagnosis? And the answer actually is still yes for many diseases, but certainly not for all. And that's what we'll cover more about today. If I can't resolve this just with morphology, can I resolve these questions with immunohistochemistry? And if immunohistochemistry isn't enough, are there likely to be helpful molecular genetic findings? All right, so again, this is another one that kind of comes up, particularly when you're dealing with a very sophisticated audience, clinicians in a sarcoma center, people like an audience like yourselves. So this isn't the 1970s. Why should we bother with all this morphology stuff? Well, you know, microscopic evaluation of slides is simply a highly specialized form of physical diagnosis. That's all it is. And like an excellent physical examination, it still serves as the cornerstone in the evaluation of our patient. So all I'm doing is beginning my evaluation of this patient by looking at a physical examination. The other thing is that morphologic triaging gives us a framework within which to interpret all of these immunohistochemical and molecular genetic findings that we're going to have, because, as I hope to emphasize over the rest of this talk, few, if any, of these immunohistochemical or molecular genetic tests are meaningful outside of the appropriate clinical morphologic context. All right, so let's go now and start to talk a little bit about immunohistochemistry. This is actually the beginning of diagnostic immunohistochemistry. This paper from 1981 from a German group. They looked at intermediate filaments, in the identification of human tumor cells. And there was a lot of optimism at the beginning. In general, the immunologic features of tumor cell intermediate filaments are those present in the tissue of origin. It can be seen, therefore, that during neoplastic transformation, there are no major changes in the synthesis of the type of intermediate filament protein when compared to normal tissues. And because of this, this was going to be a quick and clear-cut way to differentiate tumors of different types. And the original idea was that keratins would be in carcinomas, vimentin in sarcomas, desmin in tumors of muscle origin, neurofilaments in neural tumors, GFAP in gliomas. But probably within about a week of this tumor being published, it became obvious that tumors didn't obey these rules. Here's just one example that kind of will show this. This is a sarcomatoid squamous cell carcinoma. This is the sarcomatoid part. Here's a more conventional basaloid component. And if we stain this tumor for keratins, as expected, the conventional component is keratin positive. But already we're starting to get a little bit of confusion because this sarcomatoid component is actually keratin negative. And it actually gets worse because whereas the conventional component is vimentin negative, vimentin expression is a new feature, a novel feature now of the sarcomatoid carcinoma. So it became quickly very apparent that intermediate filaments, while helpful, were by no means going to be enough. So we moved on to what we might call the second generation of markers, which tend to be lineage-associated cytoplasmic and membranous markers. And we still use almost all of these, and they can be grouped into various families. We have epithelial markers listed here, nerve sheath markers, endothelial markers, a lot of melanocytic markers. We still use various muscle proteins, neuroectodermal markers. And these are all tumors that we still use very routinely, and they're quite helpful. So just to give a couple of examples applicable to sarcoma pathology, this is an epithelioid malignant peripheral nerve sheath tumor, very nested, tends to have big prominent nucleoli, and it's usually diffusely positive S100 protein, which is different than other types of malignant peripheral nerve sheath tumor. Another tumor, Ewing's sarcoma here, it's a primitive round blue cell tumor, and we know that CD99 expression, while certainly not specific, is a very, very sensitive marker of Ewing's sarcoma. And so we use this as a screening tool to help to decide which cases of possible Ewing's sarcoma need more advanced testing. We then moved on to what we might call a third generation of immunohistochemical markers, and these tend to be lineage-associated transcription factors. So we have markers such as myogenin and MyoD1, which are transcription factors expressed during skeletal muscle differentiation. PAX7, also a skeletal muscle marker. Brachyury is a marker of notochordal tumors, and a variety of other markers listed here, many of which are in fact markers of carcinomas. And we still use these obviously quite a bit in the diagnosis of carcinoma of unknown primary. So the group listed over here. So these are interesting markers, and we can do some kind of creative things with them as well. This is an alveolar rhabdomyosarcoma sarcoma. It's a malignant round blue cell tumor that grows in a nested pattern, and it's typically very, very diffusely positive for myogenic. Now, this is a somewhat different tumor. This is called a spindle cell and sclerosing rhabdomyosarcoma. It also grows often in a distinctly nested pattern, but it has a different looking matrix, and the cytology is a little bit different. Now, when we described this tumor, a lot of pediatric pathologists said, well, you're kind of wasting your time. These are obviously just alveolar rhabdomyosarcomas. But we now know, of course, that they were incorrect. These tumors are negative for myogenin in most cases, and they show very, very strong positivity for MyoD1, which reflects their underlying MyoD1 L122R mutation. So in this case, the expression of these markers not only helps us in classification, but it gives us some clue to the underlying genetics. Where we are now is what Jason coined this term. He calls these next generation immunohistochemistry. It's kind of a sexy term, so I'll use that. And these are surrogate markers of underlying genetic events. And so basically the idea now, and we'll go through some of these, is that as we increasingly understand the molecular genetics of sarcomas, we can develop immunohistochemical assays that allow us to use immunohistochemistry rather than molecular genetic techniques. So essentially, we're using protein molecular diagnostics instead of genetic molecular diagnostics. So just to show you a couple examples of that, this is a desmoplastic round cell tumor. These usually present as very extensive, multicentric intra-abdominal disease in young patients, usually males. Morphologically, they have this very striking desmoplastic background, where the name comes from, as well as these nests of very primitive round cells. This was actually the first one of these surrogate markers to be developed. This was back in the early 90s, where it was shown that antibodies to the carboxy terminus of WT1 could identify these tumors, and that's reflecting the EWSR1 WT1 fusion seen in these tumors. Another more recent example, this is something called a pseudomyogenic cholangioendothelioma. These have a fusion involving the SERPINE1 and FOSB genes. They usually present as multicentric, often ulcerated skin lesions. They can involve muscle and bone as well, usually in young males. And they're morphologically very challenging lesions because although we think of them as endothelial tumors, they actually show no morphologic evidence of endothelial differentiation and instead mimic either an epithelioid sarcoma or some type of myoid tumor. Because we understand the molecular genetics of this tumor, we can use antibodies to FOSB, which are typically diffusely and strongly positive in a nuclear pattern, to basically imply the presence of this fusion event and make this diagnosis in the appropriate context. Another example here, synovial sarcoma. Synovial sarcoma has somewhat complicated genetics. It either has fusions of SS18 or less commonly the SS18L1 gene. to one of these members of the SSX family. Now, this was an interesting patient who presented with a brachial plexopathy and was found to have a fusiform expansion of the brachial plexus. Rob Spinner did this case, and Rob was obviously very, very pleased with the dissection that he did. You can see all the branches of brachial plexus nicely labeled for us. And the clinical presumption was that this would be a malignant peripheral nerve sheath tumor. And in fact, the morphology is acceptable. It's a monomorphic spindle cell tumor in part with a hemangioparasarcoma-like pattern. But in fact, this was a monophasic synovial sarcoma occurring as a primary tumor within the nerve. This lesion was positive actually for an SSX4 fusion and is positive here for this SS18 SSX fusion protein antibody, which we're now using here. And this turned out to be really an excellent protein surrogate for molecular genetics. There's different types of events that we can detect. We've looked at fusions so far. We can also look for deletions. And so this is an epithelial sarcoma, which are characterized in almost all instances by deletions of the SMARCB1 tumor suppressor gene. Epithelial sarcomas, as you know, usually present as ulcerated, indurated masses of the distal extremities, often with multiple lesions, as shown here. The morphology is quite characteristic. These rather uniform, small epithelioid cells with a tendency to spindle. And if we look at SMARCB1 expression in the tumor, you can see that the tumor cells are completely negative, whereas the endothelial cells and lymphocytes are positive, giving us an internal control. And again, in this morphologic and clinical context, this confirms diagnosis of epithelial sarcoma. One final example here is a tumor actually described at Mayo Clinic by Dr. Carney as melanotic schwannoma. We now call it a malignant melanotic nerve sheath tumor because they're actually more often malignant than benign. Now, these are tumors where we know that the patients usually have mutations in the PRKAR1A gene. This is an example of a melanotic schwannoma. They're often paraspinal lesions. They're jet black in appearance, mimicking a melanoma. They can behave in a malignant fashion. Here's one with metastasis to the lung. You can see all the pigment within it. And we can use loss of PRKAR1A expression as a diagnostic reagent to help us distinguish malignant melanotic nerve sheath tumor from melanoma, because melanomas show retained expression. What's also interesting is that whether or not we know the patient has this syndrome, the tumors seem to lose this protein. And so perhaps melanotic schwannoma or malignant melanotic nerve sheath tumor by itself is actually a form fruste of Carney complex. All right, now genetics and sarcomas have become very, very complicated, as close to as complicated as heme path is, or perhaps even a little bit more complicated. This is actually 2 of the 3 pages of genetic events from a textbook that Peter Nielsen and I wrote. There will be a quiz at the end, so you probably want to start memorizing all of these right now. The 3rd page is available, assuming you own the book. But what we'll do is we'll try to go through some of these genetic events just in the context of what I might consider groups of tumors, sort of the way that the pathologists tend to approach these lesions. So we'll start off with adipocytic tumors. This is an example of a pleomorphic liposarcoma, lots of pleomorphic lipoblasts, obviously malignant bizarre tumor cells. Now, genetics are very important in the classification of lipomatous tumors. We know that the tumor we call atypical lipomatous tumor or well-differentiated liposarcoma, depending on its location, as well as the high-grade form, Ddifferentiated liposarcoma, share genetic events, which are amplifications of a variety of genes, most importantly MDM2 and CDK4. And we can detect this with a variety of methods, including immunohistochemistry, chromogenic in situ hybridization, and the most specific technique, which is fluorescence in situ hybridization. Another type of liposarcoma, Mixoid liposarcoma, and its high-grade variant, also called round cell liposarcoma, are characterized by fusion events, usually FUS fused to DDIT3, less often EWSR1 fused to DDIT3. And we can detect this either by immunohistochemistry for DDIT3 or by molecular genetic tests looking for this fusion event. Pleomorphic liposarcoma, the one illustrated here, doesn't have any specific events. And there's a very, very rare tumor that I'll touch on a little bit at the end called Mixoid pleomorphic liposarcoma, which turns out to have near haploidization as its genetic event. So this is one of the liposarcomas we might use this testing for. This is a lipoma-like atypical lipomatous tumor where most of it is composed of mature fat. There's only an occasional hyperchromatic cell. I think a lot of pathologists would be a little bit uncomfortable making the diagnosis of a malignant lesion, so they look for some help. You could karyotype this tumor, and what you see when you karyotype it are these giant ring and marker chromosomes. You could look by chromogenic in situ hybridization for MDM2, which is shown here. And I show this one just because it looks like the immunohistochemical study as well. But the best test is fluorescence in situ hybridization, which looks for amplification of the MDM2 gene, shown here as these multiple blobs of red. And I'll cover why, we'll touch a little bit on why these other techniques are a little bit less specific. All right, now this is a question that comes up a lot, and for the surgical pathologists in the audience, you might want to save this slide. When should you fish adipocytic tumors? Well, the general agreement is you should fish them when they're recurrent, because we're worried, of course, that it might be a very subtle atypical lipomatous tumor. It's probably reasonable to fish very big tumors and tumors occurring in older patients. Cases with equivocal atypia, I don't know exactly what this means, but basically, if you're not sure, there's probably no harm in doing it. It is obligatory to fish fatty tumors of the retroperitoneum, pelvis, and within the abdomen, because you can't make the diagnosis of lipoma in these locations without showing that it's MDM2 negative. In special clinical situations, as indicated, again, I don't exactly know what this means, but it basically means if you want to, go ahead. But I guess the thing I'd like to emphasize is that you don't have to fish every fatty tumor, okay? We can confidently diagnose benign lipomas without spending a lot of money on molecular genetics. And I think the great majority of atypical lipomatous tumors can also be recognized if we sample them carefully and look at them closely. And so again, I would encourage you to share these kind of cases before ordering molecular testing. We can do this cheaply and quickly just with our eye. All right, so why is MDM2 fish superior to immunohistochemistry or chromogenic in situ hybridization? Just a couple examples here. Fat necrosis is probably the single most common mimic of atypical lipomatous tumor. It contains these lipid-laden macrophages, and that's kind of what mimics liposarcoma. Unfortunately, lipid-laden macrophages are routinely positive for MDM2 by immunohistochemistry. Again, so big pitfall. We see this all the time in the consult service. This is a sort of a peculiar tumor. This is something that's been referred to as dysplastic lipoma. I don't actually think this entity exists. My own feeling is that these are spinosal lipomas with fat necrosis. Be that as it may, for some reason, these tumors show multiple copies of MDM2 on chromogenic in situ hybridization, but lack amplification by fish. So again, it's basically sort of a funny false positive that you see with KISH, but not fish. Turning to Mixoid liposarcoma, this is a lesion that in almost all instances we confidently recognize just on histology alone. Delicately arborizing capillaries, myxoid background, small cells, lipoblasts. The harder cases are these so-called round cell liposarcomas, where it can basically mimic some other type of small bone round cell tumor. We actually use fish testing for the most part for DDIT3 here at Mayo Clinic, but there are actually antibodies available to DDIT3, and as you can see, they're very nice, very robust markers of myxoid liposarcoma and of these high-grade forms. So, you know, for the trainees in the audience, if you go out somewhere and you don't have access to fish, you might want to consider buying this antibody for your lab. Moving on to another big group of tumors, the pleomorphic spindle cell sarcomas, and I just exemplify that with a myxofibrosarcoma here, a very common tumor of the superficial soft tissue in older adults. Pleomorphic spindle cell sarcomas are overwhelmingly the most common adult sarcoma subtypes in sporadic settings, post-radiation settings, and also familial, like Lee-Fraumeni setting. There are a number of different types of them. They're all shown here. I'm not going to necessarily read them all off. But of this big list of pleomorphic adult soft tissue sarcomas, only ddifferentiated liposarcoma harbors a characteristic genetic event, which we've already talked about, MDM2 amplification. Now, one thing that is important to know is that MDM2 amplification is not specific for ddifferentiated liposarcoma. You can see it in other pleomorphic spindle cell sarcomas. And so you have to be careful not to overinterpret MDM2 amplification. So my own philosophy on this is that pleomorphic sarcomas in the retroperitoneum, because they're so likely to be ddifferentiated liposarcomas, those all get MDM2 fish. tumors in the extremities, unless there's any radiographic or clinical suggestion that they're related to liposarcoma, I don't bother fishing them. Just an example of ddifferentiated liposarcoma. Here's the well-differentiated component, fibrosepta, weird-looking hyperchromatic cell, mature fat. It gave rise in an abrupt fashion to this undifferentiated high-grade sarcoma. If this was all we had in a biopsy in a retroperitoneal mass, it would be very reasonable to fish it, and we would almost always find this amplification pattern of MDM2. Moving on, another group, monomorphic spinosal sarcoma. We touched on this already with the case of synovial sarcoma. This is actually a malignant peripheral nerve sheath tumor, which is another one of the monomorphic spinosal tumors. This lesion is actually making tactoid bodies, which are quite rare and actually absolutely positively diagnostic of MPNST. Unfortunately, we don't see these very often. So there's sort of a laundry list of monomorphic spinosal sarcomas shown here, and actually many of them have specific genetic events. And so this is another group where we tend to use molecular genetics quite a bit. Synovial sarcomas, we've already touched on. Malignant peripheral nerve sheath tumors have fusions which result in loss of the trimethylated form of this particular histone. And so we can use immunohistochemistry or also increasingly molecular genetic techniques to look for loss of this trimethylated histone. Dermatofibrosarcoma protuberans and the fibrosarcomas arising there show PDGFB amplification. Low-grade fibromyxoid sarcoma and related sclerosing epithelioid fibrosarcomas have these fusions involving either the FUS and CREB3L2 gene, or less often the EWSR1 and CREB3L1 genes. Solitary fibrous tumor, NAT2 STAT6, which we detect with immunohistochemistry for STAT6, and the MyoD1 mutation that we've already seen in spinosal rhabdomyosarcoma. So here's a monophasic synovial sarcoma, a little bit different than the one that we saw before, a little bit less cellular. They often have calcifications, which can be a clue. A good radiologist will often suggest monophasic synovial sarcoma for a soft tissue mass with speckled calcification. And as I've shown you earlier, these tumors are typically quite strongly positive with these antibodies directed either to the fusion protein or to the C terminus of the SSX protein. And there's some interesting things that happen. We actually had a case recently that was C-terminal positive, fusion protein negative, and that's a lesion that almost certainly has an SS18L1 fusion rather than an SS18. So again, you can kind of infer the molecular genetics by understanding the immunohistochemistry. Genetics of synovial sarcoma, as I mentioned, tend to be somewhat complex. Most of them have this SS18, SSX1 fusion that tends to correspond to the monophasic variant. Some of them, about a third, have SSX2. These are more often biphasic. There's not really perfect correlation between fusion type and whether they're monophasic or biphasic. There's also no real correlation between behavior and fusion type. And then again, some of these cases have these rare fusions, and this was more important when we use techniques such as RT-PCR, which would only detect these fusions, or FISH for SS18, which would only detect these 3 fusions but miss this one. Now with next generation sequencing, we tend to pick up all of these. Fibrosarcoma to stromatofibrossarcoma. This is a nice clinical example. This patient had a long-standing recurrent DFSP, these smaller nodules, which grew very, very rapidly to form this tumorous mass, clinically highly suggestive of fibrosarcomatous progression. Areas within it show conventional DFSP with this store form proliferation of kind of monomorphic cells growing through fat. Other areas are fibrosarcoma with a more fascicular pattern, easily identified mitoses, and higher nuclear grade. In cases that consist chiefly of this element, we can confirm the diagnosis with fluorescence in situ hybridization for PDGF beta, which shows both rearrangement as well as amplification. This can actually also be of theranostic significance because fibrosarcomatous DFSPs have been shown to respond to Gleevec, and insurance companies will generally only pay for Gleevec if they know that the tumor is PDGFB amplified. Moving on to another group of tumors, the primitive round cell tumors. This is a group where obviously we use molecular genetics very, very extensively. And in many respects, molecular genetics are essential for the diagnosis of many of these lesions. The prototype is Ewing sarcoma, which was originally described as showing EWSR1 Fly1. Then it was noted that a smaller percentage of EWSR1 ERG, but we now understand there's probably about 12 or 13 different Ewing sarcoma fusions involving a wide variety of different partners. Molecular genetics is very important in the diagnosis and subclassification of the alveolar variant of rhabdomas. I'm sorry, what? The alveolar variant of rhabdomyosarcoma, which shows fusions involving either the PAX3 or PAX7 gene with the FOXO1A gene. And there are clinical differences between PAX3 and PAX7 harboring tumors. So actually, there's now increasing clinical evidence, not only in diagnosis, but in molecular subclassification. We are now moving into an area where some of these round cell tumors are actually defined by their genetics. And so we have tumors such as a CIC sarcoma, defined by CIC rearrangement, B-core sarcomas defined by rearrangements and internal tandem duplications in the B-core gene, desmoplastic plus round cell tumor we've talked about already, and there's really a lot of different small round cell tumors at this point. Just a few words about some of the rare ones. CIC rearranged sarcoma. This was previously classified as a Ewing-like primitive round cell tumor or as atypical Ewing sarcoma. They tend to occur in the extremities or the trunk in relatively young patients. They look a little bit different than Ewing sarcoma. They tend to have a little bit more cytoplasmic variability. The nuclei are a little bit different looking than Ewing's. They more often show some mixoid change as well as mitotic activity and necrosis. Why does it matter? Well, they're more aggressive than Ewing sarcoma. The 5-year survival is considerably worse, and they don't seem to respond quite as well to Ewing chemotherapy. These are challenging lesions, both or morphologically, immunohistochemically, and actually at the molecular level. They have a variety of different partners. And for reasons that we don't totally understand, it can be very difficult to identify CIC rearrangements, even if you use NGS and FISH or both. And these tumors often require correlation between the surgical pathologist and the molecular pathologist, where we go back and forth and say, you know, is it possible there's a fusion present at low levels? Can we look again? Immunohistochemistry turns out to be helpful here because as a result of these fusions, these tumors show overexpression of the WT1 protein and of ETV4. And so in the right morphologic context, even when these tumors are, quote, molecular negative, we still will make this diagnosis if there is appropriate immunohistochemistry. So just to show an example, this is what they look like. It's a round cell tumor, but they tend to be a little bit more variable than Ewing sarcoma, a little bit more cytoplasm, more often show this sort of funny mixoid pattern. Like Ewing sarcoma, they can show a little bit of CD99 expression, but not typically as diffusely as Ewing's. They will be positive for ETV4, and the marker that we tend to use most here at Mayo is WT1. So again, in this morphologic context, even if the molecular comes back negative, we will often sign these cases out as primitive round cell sarcoma showing morphologic and immunohistochemical features of CIC rearranged neoplasia. Molecular testing has also had some value in the diagnosis and classification of endothelial tumors. I use an angiosarcoma, the most common one just here, malignant endothelial cells lining these primitive vascular channels. Now, it's important to keep in mind that the most common tumor, angiosarcoma, actually, we seldom, if ever, need molecular diagnosis for this tumor. Really, the only setting where it's helpful is in the post-irradiation setting. And here we're almost always talking about women who've been radiated for breast cancer. And these post-radiation cutaneous breast angiosarcomas show MYC amplification. And this is in distinction to sporadic, usually sun exposure related angiosarcomas in other locations. Now, it's very difficult to get the dermatopathologist to stop running MYC on everything, but the reality is, other than in the radiation setting, MYC amplification is really not very, very sensitive. There is a significant role for molecular diagnosis in the classification of epithelioid hemangioendotheliomas. Those have the fusion events shown here. And we've already talked about pseudomyogenic hemangioendothelioma with the SERPINE1 FOSB fusion. There are several other rather rare hemangioendothelioma subtypes, and they may have specific genetic events, but data is a little bit limited, and we're not using those so much for diagnostic purposes right now. Just to give an example, this is an epithelial hemangiopericytoma. They're usually composed of these very, very bland cells growing in this hyalinized or somewhat chondroid-looking background. You can see it's quite nicely positive for CAMP1, again, reflecting this WW2R1 CAMP1 fusion. Now, we don't need this to diagnose these conventional tumors, but the ones where it's kind of helpful are what have been referred to as high-grade epithelial hemangiopericytomas. These are lesions that are easily mistaken for high-grade forms of angiosarcoma, except they show areas which look like conventional EHE. And these tumors turn out to be CAMP1 positive, and they turn out to have the same fusion event. And it basically allows us to distinguish this high-grade form of epithelial hemangiopericytoma from conventional angiosarcoma. Just to show an example of post-radiation angiosarcoma, here is a fairly classic clinical example. This woman with this very large ecchymotic lesion, which developed several years after radiation for breast cancer. These hemorrhagic papular lesions, obviously a good clinician is going to look at this and say this is certainly angiosarcoma. Morphology, again, very characteristic of angiosarcoma, and these tumors show amplification of the MYC gene. Where we really need to use this is in the setting of what's called atypical vascular lesions, which also arise in the post-radiation setting, usually as crops of these small, somewhat erythematous or pale papular lesions. And it can be difficult for the clinicians to decide whether these are early angiosarcomas or just AVLs. They can also be challenging morphologically. This is a lesion that is growing very irregular interanastomosing vascular channels concerning for angiosarcoma, although there's no cytologic atypia. If we do fish for MYC, there's no amplification, and so it's reassuring that this is in fact an atypical vascular lesion rather than an angiosarcoma. Another group of tumors where this has been sort of interesting are soft tissue tumors showing melanocytic differentiation. We've already talked about one of those, the malignant melanotic nerve sheath tumor. This is another example, what we call a malignant gastrointestinal neuroectodermal tumor. This was a patient who was actually resected here at Mayo Clinic. This is a gastric mass, and you can see this sort of unusual fleshy-looking tumor arising within the muscularis. Molecular genetics is quite important in the classification of these tumors. Clear cell sarcoma showing usually fusions involving EWSR1 and CREB1. These malignant gastrointestinal neuroectodermal tumors showing similar fusions, but more often involving the CREB1 gene rather than ATF1. Malignant melanotic nerve sheath tumor we've talked about, in a lesion we don't often think about in soft tissue, but actually increasingly are recognizing, is melanoma arising in extracutaneous cellular blue nevus. And unlike conventional forms of melanoma, which show mutations in genes such as BRAF, melanomas arising in blue nevi have mutations involving GNAQ or GNA11. So here's a nice example of a clear cell sarcoma. This is a gross photograph that a friend of mine, Peter Nielsen at Mass General took. Peter took gorgeous gross pictures. These tumors often arise in association with tendon or aponeurosis, usually in the hands or the feet. You can see it right here. Morphology is quite characteristic, a distinctly nested proliferation of melanoma-like cells with prominent nucleoli, often in association with multinucleated tumor giant cells. Now, these tumors show melanocytic differentiation, and the distinction of them from melanoma can be quite challenging. So again, here's one of these tumors positive for HMB45. So you can't use immunohistochemistry to tell clear cell sarcoma from melanoma, but you can use molecular genetics, in this case, FISH for ATF1, which shows break apart of which shows break apart of the ATF1 locus, confirming the EWSR1 ATF1 fusion in this tumor. Example of extracutaneous cellular blue nevus. This was a patient who presented with a gigantic, largely necrotic intra-abdominal mass with no history of any type of primary tumor. When it was resected, it was a jet black lesion. Grossly, the differential diagnosis would be, again, with a malignant melanotic nerve sheath tumor or conventional melanoma. The morphology shown here could really be in any of those lesions. The melan A positivity could be seen in any of those lesions, but the genetics point us in the right direction because this tumor has a GNA11 mutation. And in fact, careful sampling of this mass identified areas of conventional cellular blue nevus. We also now, in soft tissue, are moving toward a group of tumors that we might call morphologically and genetically distinctive tumors that have no normal counterpart. And sort of the prototype of this would be the alveolar soft part sarcoma, where we spent decades trying to figure out what the normal counterpart of this lesion was, only to find that it didn't have a normal counterpart, and was in fact the result of this fusion involving the ASPCR1 and TFE3 genes. This turns out to be a recurring theme in soft tissue tumors. This is an example of a malignant ossifying fibromyxoid tumor with a low-grade component here and a high-grade component here, the characteristic shell of bone here. These tumors have rearrangements involving the PFH1 gene with a variety of different partners. We are also now recognizing tumors that have no name other than their genetic event. So we have NUT-M1 rearranged sarcomas, EWSR1 PATC1 sarcomas, tumors with rearrangements and amplifications of a wide variety of different tyrosine kinases, the best known of which is NTRK, and these other ones shown here. So it's becoming very, very complicated. An example of alveolar soft part sarcoma, these often present as fleshy hemorrhagic masses, usually in fairly young women. The morphology is really pathognomonic, this large nests of cells with abundant eosinophilic cytoplasm, typically with multifocal vascular space invasion. Because we understand the genetics, again, we can use immunohistochemistry, in this case for TFE3. This is a good screening marker. It's very, very non-specific, but it's a useful screening marker of alveolar soft part sarcoma. A much more specific method is TFE3 FISH, again, showing break apart of the TFE3 locus. NUT-M1 colorectal sarcoma is something that we described a couple of years ago. These present, as the name would suggest, as tumors of the colon. They're extremely rare. They have no age or sex predilection. They have very distinctive morphology that I'll show you in just a second. And their immunohistochemical profile is also characteristic with a little bit of weak keratin, but positivity in a nuclear pattern for the NUT-M1 protein. And that reflects underlying MDX4 NUT-M1 fusions. These are interesting because these tumors always show the same NUT-M1 fusion, and this is very different than the NUT-M1 fusion that we see in aggressive midline carcinoma, where the tumors have BRD3, BRD4 fusions with NUT-M1. So for reasons we don't totally understand, this particular fusion seems to occur only in the setting of these colonic tumors. These don't do very well. So this is just an example of what they look like. Again, they occur as primary colonic lesions. Here's the mucosa of the colon and this polypoid mass. They'll often show spindle cell features as well as areas with more rhabdoid morphology. So the morphology is quite characteristic. A bit of keratin and a lot of nuclear NUT-M1 confirms the diagnosis. Just to finish up with one, or as we're getting closer to the finish, with what are called the tyrosine kinase rearranged or amplified spindle cell tumors. This is this emerging group of soft tissue tumors defined by this molecular event. They are most often seen in children. They tend to look fairly similar, usually monomorphic spindled cells with some hyalinization. And they have a fairly characteristic phenotype where they express S100 protein and CD34, but not SOX10. Now, we originally recognized these tumors as harboring NTRK fusions, most often NTRK1, but it turns out that essentially identical lesions can have either rearrangements or we now understand also amplifications in a variety of other tyrosine kinase genes. And so we're seeing ones with ERK or RET or BRAF events. When they have the TRK rearrangements, they're positive for the TRK monoclonal antibody. When they're BRAF involved, we can show BRAF positivity. And these are important to identify because they can be treated with a variety of different tyrosine kinase inhibitors. The prototype, again, these NTRK rearranged tumors, this one with the TMP3 NTRK1 fusion, sort of bland spindled cells, often some sort of pseudo lipoblastic growth pattern, positive for CD34 and S100, negative for SOX10, positive for the pan-TRK antibody. This tumor has somewhat similar morphology, again, kind of a monomorphic spindle cell tumor growing in infiltrated fashion through skeletal muscle, again, rather bland spindled cells. This tumor had a Brap B600e mutation, which we can detect in this case with immunohistochemistry. There's one final group of lesions just to mention here, the matrix-producing soft tissue tumors. Some of those have characteristic rearrangements, although the truth is we really don't need molecular genetics to diagnose most of these tumors because they're really diagnosed chiefly in morphologic patterns, which are very, very characteristic. We do know that many of them have specific genetic events, mesenchymal chondrosarcoma, this Hay1-NCA2, extraskeletal mixoid chondrosarcomas with a variety of events involving NR4A3 rearrangement, phosphaturic mesenchymal tumors, which I'm somewhat obsessed with these fusions, and the list sort of continues. Now, what's kind of interesting about them, and it reflects the way that our approach to soft tissue pathology has changed over the years, I think is nicely illustrated by mesenchymal chondrosarcoma. Now, mesenchymal chondrosarcoma has been with us for a long time. It's a lesion that was recognized and diagnosed many years before molecular diagnosis came about. They often present as partially calcified or chondroid-appearing lesions in the soft tissue of bone. You can see the gross photograph corresponds very nicely to the radiograph. Again, these areas of cartilage as well as areas of ossification within the lesion. And the morphology is a slam dunk. I mean, we don't need to do anything to these tumors except look at them under the microscope. These areas of round blue cells juxtaposed to cartilage. Now, what turns out to be kind of interesting in these tumors is that they essentially all show skeletal muscle differentiation at the immunohistochemical level. They're typically positive for desmin, and they show considerably more extensive expression of MyoD1, occasionally with a little bit of myogenin as well. Now, why is this? This is because it is almost certainly the result of the NCOA2 involvement in the fusion that characterizes these lesions. We now understand that there's a related family of NCOA2 rearranged rhabdomyosarcomas, sometimes involving bone and showing this MEIS1 fusion, sometimes involving soft tissue, showing more of a smooth muscle appearance and having, in this case, this zinc finger 64 fusion, and other times occurring in a congenital presentation in children and having rearrangements of the SRF locus with NCOA2. And the truth is, just philosophically, if we were describing mesenchymal chondrosarcoma today, we would probably be classifying it as a form of rhabdomyosarcoma, which shows cartilaginous differentiation. So it just shows that, as we make advances in molecular pathology, it sort of changes the way we think about tumors. Now, no one's going to reclassify mesenchymal chondrosarcoma as a rhabdomyosarcoma. All right, so with all of these sexy immunohistochemical surrogates and molecular events and the molecular tests themselves, why should we still bother looking at soft tissue tumors under the microscope? In other words, why not just go immediately to sequencing or whatever? All right, so let me try to give you a couple examples of why this might be a problem. So this is a 27-year-old woman. She presented to another academic medical center with a submucosal laryngeal mass. This very good academic medical center performed immunohistochemistry and molecular genetic testing, and by report, the tumor was positive for SS18 rearrangement, which again is what you see in synovial sarcoma. So the patient was referred to Mayo Clinic for laryngectomy. And, as I'm sure you all know, we review outside slides. And so this went into our MC3 area and they were reviewed on this surface. And pathologists who looked at it said, well, it kind of looks like a synovial sarcoma and it's SS18 positive. So the diagnosis was confirmed. So the patient went to surgery at St. Mary's, and I happened to be on frozen section that day. And Dan Price, one of our head and neck surgeons, sent this frozen for me to take a look at. Thankfully, Dan was able to do a subtotal laryngectomy with negative margins. And when I looked at this at the time of frozen section, I said, hold on here. This is a really well circumscribed mass. This doesn't make a lot of sense for synovial sarcoma. Dan, your margins are positive. Let's get back to this thing tomorrow. So when I looked at it the next day, it had this branching vascular pattern of these sort of haphazardly arrayed cells. It was positive for CD34, positive for STAT6. This is obviously a solitary fibrous tumor rather than a synovial sarcoma. We repeated the FISH for SS18 here, and it was negative. So this was a false positive FISH at the outside institution. Here's another case. This was a 68-year-old man. He had a history of multiple skin tumors related to sun exposure. He presented to, again, another academic medical center with a mass involving the parotid. The outside laboratory showed that the tumor was positive for S100 protein SOX10. It was actually negative for HMB45 and melanocytic, but it was reported to show an EWSR1 rearrangement, which in this context would point toward clear cell sarcoma. And so the case was sent to me in consultation as a clear cell sarcoma involving the parotid gland of an older patient. Now, the morphologic features of the tumor are actually those of a spindle cell malignant melanoma. Spindle cell melanomas tend to show very, very diffuse expression of S100 without expression of melanocytic markers. We know from our own experience here that conventional melanomas often have abnormalities involving chromosome 22, which is where EWSR1 lives, and that these chromosome 22 abnormalities can be misinterpreted as EWSR1 rearrangement. And when we repeated the fish here with our very, very good fish people, Bill Sukoff and others, EWSR1 was negative. All right, so why do you get false positive fish or RT-PCR results? Well, again, you can have deletion of nearby genes. So for example, tumors that have SMARCB1 loss can be misinterpreted as showing EWSR1 rearrangement. You can also score them badly. So basically, places that have inappropriately low cutoff thresholds we'll sometimes call false positives. It's also fairly common for aneuploidy with whole or partial chromosome loss to be misinterpreted as rearrangement of a locus. And this is actually what usually is going on in melanoma. And then, of course, there's a variety of human errors ranging from simply poor technique to actually contamination with RT-PCR. There was a famous controversy in soft tissue pathology about whether tumors other than synovial sarcoma showed the SS18. And it turned out that all of the data was actually related to contamination. All right, the other problem that we run into, why you can't just do genetics, is that, as you probably noticed already, these genes are promiscuous. And so EWSR1 and FUS are two of the most promiscuous genes. And you can see this laundry list of different tumors, which not only show rearrangements of EWSR1, but can actually also alternatively show rearrangements of FUS. All right, so, just knowing that it's EWS or FUS rearranged doesn't help you a whole lot, right? Well, okay, so that's well and good, but this is Mayo Clinic and it's 2023 and we're very sophisticated and we want to do next generation sequencing or now whole exome sequencing, and that's going to solve all these problems, right? All right, well, here's the first problem that I'm sure any of you who are involved with this know about, which is that there's just fusions everywhere. I mean, this is preliminary data from when we just began doing this, and there are all kinds of tumors that we never had any idea had fusions. Atypical lipomatous tumors, look at all these fusions. What do they mean? We have no idea. So it turns out that these fusion events are much more common than we originally thought. And again, we need to understand and perform the appropriate bioinformatics to determine which ones are actually significant and which ones aren't. So just finding the fusion by itself is not going to help you that much. The bigger problem is that it turns out that different tumors have identical genetics, okay? So here's a clear cell sarcoma. It has EWSR1 ATF1, so that's a malignant soft tissue tumor. Here's one of these gastrointestinal neuroectodermal tumors. These are really, really aggressive, more aggressive than these. They also have that fusion. Here's a benign, basically benign pediatric tumor called angiomatoid fibrocystic. It's got the same fusion. And you can even see that in carcinomas of salivary glands and these weird mixoid lesions of the CNS and the lung. So, if all you did was take the tumor and throw it into the next generation sequencing box and it came back with EWSR1 ATF1, I don't think the clinicians would be terribly happy with you telling them, well, it could be either benign or malignant, right? I mean, we need to know what it is in order to know how to interpret the molecular genetics. Here's another example. This was something that we reported a year or so ago. This was an interesting case or series of tumors that involved the gynecologic tract, usually in a fairly young woman. Here's one involving both the uterus as well as the ovaries. It's this sort of weird looking spindle cell tumor. It's quite bland. It's got thick walled vessels. It doesn't, take my word for it, kind of look like anything in particular. It tended to show a fair amount of desmin. So why am I showing it? Well, it turns out that these lesions all have the EWSR1 WT1 fusion. And this was the first report of this fusion showing up in any tumor other than desmoplastic round cell tumor. In fact, we had always thought that this was really the sacrosanct fusion. We were never going to find anything else that had it, but In fact, the morphology of these lesions is just not even close to that of desmoplastic small round cell tumor. And what's actually kind of interesting is if you do gene expression profiling on our tumors and compare them to desmoplastic round cell tumors, they have completely opposite gene expression profiling, indicating that despite the fact they have the same fusion, their expression patterns are quite different. So again, just knowing the fusion doesn't tell you what it is. There are also tumors that have very unusual genetic events, so you're not going to detect them with next generation sequencing. So here's a lesion that I've been interested in called an inflammatory rhabdomyoblastic tumor. It's this kind of weird low-grade tumor that shows skeletal muscle differentiation. Here's another tumor that we described a few years ago called Mixoid Pleomorphic liposarcoma. It's a very aggressive liposarcoma of the mediastinum, usually in children. Why am I showing them together? Because they both are characterized by near haploidy with massive loss of heterozygosity. And this is something you're generally not going to detect, obviously, with a fusion assay. We actually detect this with OncoScan, looking for loss of heterozygosity. This is what the karyotype looks like in an inflammatory rhabdomyoblastic tumor. One copy of basically every chromosome except for 5, 20, and 22. This is from Christina Antonescu, looking with a different technique, an allelic log odds ratio plot, which Dr. Antonescu swears shows that this also shows near haploidy. She's much smarter than I am, so I'm not going to attempt to analyze this myself. All right, so with that, we come to the end. So hopefully I have persuaded you, or at least made you more aware that the pathologic evaluation of soft tissue tumors is really very complex. And we have to integrate all the information we have available to us: clinical, radiographic, morphology, immuno, and molecular. The molecular genetic findings, although they're critical for the diagnosis of some tumors, obligatory even for some, are really only meaningful when they're interpreted in the overall clinical and morphologic context. There are many soft tissue tumors where we don't need to do any ancillary testing. We can just diagnose them on the H&E, and although that sounds old-fashioned, it works. And why should we continue to do that? Well, we're all in a resource-constrained environment. I mean, whether we're relatively well off like Mayo Clinic, or whether we're truly in a resource-constrained environment like in a developing country, it's important to use molecular genetic testing in a cost-effective fashion, because we don't want to waste this testing and then not have it available for the cases that truly need it. So, particularly when we start to get into issues of doing whole exome sequencing or doing these very elaborate theranostic panels like the Mayo Large Cancer Panel, we should really only be doing that in patients where they need that information in order to guide their therapy. In other words, if you're just going to cut the thing out and surgery is going to cure it, why bother, right? Thank you very much.
Thank you for participating. Please click the button below to complete the evaluation and obtain credit.